Good morning, everybody. It's a great honor to present our guest speaker today, Dr. Crum, Professor of Pathology in Harvard University and the Director of Women's and Perinatal Pathology at Brigham Women's Hospital. Dr. Crum had his medical degree from the University of Virginia, where he stayed as a resident. He went to do his fellowship at Columbia in New York, where he stayed as an assistant professor. He went back as an associate professor in Virginia till 1990, when he took the position in Harvard, and he stayed there since then. Obviously, Dr. Crum is very well known in the field of gynecologic pathology, received several awards, very well published, hundreds of papers, very well funded. He currently holds 2 DoD grants. Great researcher. We learned so much from him over the years. In the field of gynecologic pathology, if you say the name Crum, what comes to mind to our residents? Of course, you remember the SEE-FIM Protocol for processing fallopian tubes, and we just talked about that last week. That was his main paper in 2005. Before that, he used, when P63 was first cloned, he used it to identify and characterize reserved cells of the cervix and how it is a common pitfall for us for diagnosing dysplasia. Before that, his work was key in understanding the dichotomous nature of vulvar cancer and how many cases of vulvar cancer are not HPV related. He was one of the first leaders who taught us how to characterize and distinguish cervical dysplasias based on HPV typing, and the list goes on and on. As I said, we learned so much from Dr. Crum over the years. So last night, Molly and I were led by Miriam, decided to give back to Dr. Crum something, and introduced him for the first time to the beer can chicken. It was confusing because we didn't know whether the chicken goes inside the can or you put the can into the chicken. But we sorted it out last night for Dr. Crum. Dr. Crum.
Thank you. Thank you very much. That was great. And it's great to be here. My last visit here to speak, I think, was in the late 1980s. And it was a great trip even then. You mentioned the beer can chicken. We're having our fellows send off tomorrow, and I'm going to give one of them a $25 gift certificate to Chick-fil-A because he's going down to North Carolina where there's a lot of Chick-fil-A places. I'm sure that's going to raise some eyebrows. Probably the biggest honor I ever got was one of my friends recently was speaking to a bunch of young residents, I think, in Seattle. And he said, Crum did this work in the fallopian tube, and one of them said, oh yeah, and his father did something in HPV. Shows you how old I've gotten. That was fun. Anyway, I don't know if you have to darken this or not, but we'll just do it. So, I'm going to talk about just a couple of topics which pertain to the pathology of gynecologic cancer prevention, which is kind of a strange way to express it, because many of you who are not pathologists or not card-carrying pathologists might say, well, there are other people doing it as well. But I mention this because I think that sometimes a pathologic observation can change the way we think, and I think it gets to the point that you really have to understand where tumors come from to really be able to make be able to formulate a way to try to prevent them. And in both the cervix and in the ovary, it's been difficult for years, and it still is, as I'll try to illustrate as we go along. So we'll talk just about a couple of topics. I have no disclosures. There's this moonshot issue that you're all aware of, which is a fairly typical way in which the higher up admins in the government try to look at the solution to cancer. Richard Nixon had his war on cancer, and the moonshot issue, and I'm always a little bit put off by this because usually it means that we're going to get a bunch of people together and spend a lot of money on consortiums, and as opposed to funding individual investigators, which I think is far more important than coming up with a fancy term. I sat on a committee to grade grants that was it called the Dream Team, dream teams in ovarian cancer prevention. And most of these are not a dream when it's over. And in talking to a friend of mine, Branch Moody, who does rheumatology research at the Brigham, he said most large program projects don't do anything. He said I was on one that was an $18-20 million. He said there was one paper, one real paper, right? The rest was people ended up spinning off stuff of their own or not really focused on what was going on. So I'm not big on moonshots. The Gardasil issue, as you know, is a tremendous advance in prevention of cervical cancer. They now have Gardasil 9, which addresses 9 different HPV types, and really promises to eventually eradicate cervical cancer where it can be given. Some of the weaknesses of the vaccine, as you know, it doesn't get rid of existing HPV, and so you probably have millions of women throughout the world who are really beyond the point where vaccine will really help, but cannot be really covered by the vaccine, and are going to be at risk for getting cancer because they're underserved. And as you know, there's about 500,000 new cases a year, and about a quarter of a million women who die of the disease still in a lot of these countries where it's difficult to get vaccinated, particularly in sub-Saharan Africa. But there's an interesting observation that Ralph Richard told me about when I was at Columbia back in 1979, which was there was a practitioner in Boston who years ago had this habit of sort of cauterizing the cervix after every delivery. He would just take a small cautery thing and cauterize the cervical mucosa. And what he noted anecdotally was he never saw any cancers in his population. Hard to say what that really means in a person practicing with a population that actually comes in and gets looked at. But the observation he made was that he thought that cauterizing the cervical transformation zone, or the OS, would reduce cervical cancer risk. So it takes us to the question, at least in terms of how we're going to approach the cervix, and the question was, why does a cervical carcinoma develop near the squamocolumnar junction? And this was a question that for years has never really been addressed because no one really had an idea what was there that might be at risk. It was just known that that was the site. And I think one way to sort of segue into this is to look at P63 in the cervix, which we started doing several years ago with Frank McKeon. And what McKeon did was he cloned P63. They pulled it down from using a number of probably low stringency hybridization with P53 and other similar genes like P73. They were able to find P63. And it's a homologue that of P53 and probably the predecessor of P53 in terms of historically, if you will, that is very strongly expressed in basal cells of the skin. And as you know, if a mouse doesn't have P63, they don't make skin. They die within about a few hours of birth. But what it does is it's necessary for the skin stem cells, but it also is strongly expressed in the reserve cells of the cervix. So your first impression might be, well, maybe reserve cells or stem cells. That's what many of us always thought. So if you do look at embryogenesis, and you look at the developing mouse, for example, as the squamocolumnar junction or the vaginal mucosa changes during embryology, you have an induction of P63, which transforms these sort of embryonic cells into squamous cells. You get a basal cell population develop very much like reserve cells, and then what you end up with, of course, is a well-epithelialized urothelium and vaginal epithelium because it's been induced. And if you knock out the gene, if the gene's not there, and then you examine the fetal or the neonate, usually the dead neonate's genital tract, you'll find out that although the uterine mullerian epithelium looks pretty normal, where you would have found squamous epithelium, you find what we might call progenitor cells. They're the progenitors that could not transform or not move forward to become or induce P63. And when we looked at this back in 2000, around 2000, 1999, we said, that's interesting, but there was nothing else to say at the time. And you saw the same thing in the bladder, as you might expect. In fact, women or children who are born with mutations in P63, they aren't born without skin, but they have abnormal skin, and they have abnormal urothelium, as you might expect. As we'll go forward, this is also influences the esophagogastric junction, because that's where you also have to have squamous epithelium that you don't have in the P63 knockout. But around that time, we did just a quick study because I was curious how P63 was expressed in the cervix. So what we did was we took microglandular change, which is basically a proliferation of small tubular gland-like or acini in the cervix that occurs a lot in young women. Now, the women get microglandular change, which is completely benign, and it terminates in squamous metaplasia. So I said, well, let's just stain it with P63 and see what's going on. What we found was when you look at microglandular change in its earliest forms, you find really no P63, and then you suddenly start finding it actually in the columnar cells or the cuboidal cells. And then if you look a little further along in maybe different maturation stages of microglandular change, you then see the reserve cells begin to kind of segregate out below the columnar cells, and then what you end up with is squamous metaplasia. So at that time I said, well, reserve cells can be made anytime. You can make them anytime. You can make them in microglandular change in the cervix, and they come from a somewhat indifferent cuboidal cell in the cervix. It's kind of like a low columnar cuboidal cell. So I said, well, that's nice, but there wasn't nothing else to say about that at the moment. But what it did show is that reserve cells are not progenitor or stem cells, and they're derived from some kind of progenitor or earlier cell following induction of P63. And they're also derived from specialized populations of low columnar cells, in the adult, this being during embryogenesis. So this then took us to P63, the esophagus, and residual embryonic cells. And for this, I give full credit to Frank McKeon, because McKeon decided to take a look at the esophagus for a couple of reasons. First, if you look at the P63 null mouse, we noticed early on that there was obviously weirdness in the top of the stomach. The stomach was not converting to squamous like it does, if there is obviously P63, and it had an embryonic population, as did the cervix and the bladder. And so what was going on? And the reason Frank McKeon decided to take a look at it was because when you looked at the P63 null mouse and you looked at those residual embryonic cells in the stomach, someone else came along and actually compared them to Barrett's metaplasia and decided there was a similarity in the expression pattern, suggesting that these embryonic cells that did not convert to squamous or to mature columnar in the top of the stomach might have some relationship to Barrett's. And as you know, in the mouse stomach, the SC junction is a little bit into the cardia. It's not actually at the esophagogastric junction. So what they noticed was that there is this progenitor population in this P63 null mouse. It has not become squamous, nor has it become your typical columnar that you see in the top of the stomach, in the normal stomach. And so they decided to take a look and see exactly how this all came about in the normal animal. And so Frank teamed up with Wassian, one of his colleagues and now his wife, and they attacked this particular problem by just looking at how cells develop in the top of the stomach. And I just abbreviated this with one of their images. And what they showed was in the mouse, the same thing happens that you might expect to happen in the cervix during embryogenesis. You have this embryonic population, which is in this case is actually green, and then you have it's undermined by a population of P63 positive cells, which kind of emerge. There's an argument as to whether they actually track along the stomach and replace, or they just come out of nowhere or from the top population. But the assumption is they probably emerge from this population, and then they displace the embryonic cells such that you then now have a squamous epithelium and a squamocolumnar junction. What was interesting was that the squamocolumnar junction, there was a population of residual embryonic cells that were not thrown off. And if you look at these through the microscope, they're not impressive. You see a few cells, and you can take CK7 and stain the SC junction of the cervix or the esophagus, and you'll see these cells still there. And then we took some human specimens that were embryonic or fetal losses or whatever, and the same was found as you track it through fetal life into, let's say, early childhood, or you had, and into adults, you have a residual embryonic population that sits at your esophageal SC junction. And so what they did was they created an interesting model where they basically, I think they used one of the toxins, either it was cholera or diphtheria, I forget, toxin, and they induced that in the squamous cells of the distal esophagus. And they injured those cells by induction of this toxin. And when they injured those cells, the residual embryonic cells expanded and replaced them. So basically what they are cells that seem to be capable of undergoing to take advantage and actually occupy areas that were no longer occupied by squamous epithelium, and this was their argument for this being perhaps the basis for Barrett's metaplasia. And there's good data to suggest that Barrett's metaplasia comes out of a residual population of embryonic cells. Now the problem that Frank has is Frank basically always treads into areas where he never was before, and that does have a hazard, and as you might expect. And so I remember presenting this, and we presented some of this in the context of the cervix, and people would say, that's very interesting, and then 5 or 8 years later, people start talking about it, but they don't mention you anymore. But that's normal, right? So, but I think it's certainly gaining traction as perhaps the origin. The reason it's difficult to prove is these cells undergo metaplasia and they change their phenotype. So you might argue they're not really from those cells, but there's a good evidence to suggest that. Plus, Barrett's related tumors do start at the SC junction, as opposed to squamous carcinoma of the cervix, which is more proximal, unlike the cervix, right? So they identified these cells, and we asked the question, could there be something like that in the cervix? I took one look at that and said, well, we got to look at the cervix, because that'll help you prove whether this is a valid concept or not. So we got Michael Herbst, who was a young postdoc from Belgium. A year before, he said, I want to come to the Brigham and do HPV, and I said, no, you're going to do ovary or fallopian tube. And he said, I want to do HPV. And so I said, and so we kind of identified this question about 2 months before he came, and so we put him on this. And Michael loves immunology. He wanted to do immunology and all this stuff. And I said, no, you're going to look for SC junction cells. And about a month later, he said, aha, because it was pretty easy to see them just staining with CK7. There's something going on. So what he did was he did beautiful work. He microdissected the junction versus the squamous epithelium versus the normal endocervical columnar, and was able to separate them, and identify SC junction specific markers. And CK7 was an excellent one among a number of other markers that were published in the PNAS article. And if you look at the embryogenesis of this, it's pretty much as you might expect. In the mouse cervix, you start off with the cells being undermined or knocked off, and then they're retained at the SC junction. And in the human, you can see the same thing. And so what we decided we discovered was we probably discovered maybe the cells that might be important for cervical cancer, because they're unique. They're not typical of the endocervical columnar or the squamous, and they stain strong with keratin 7 or cytokeratin 7. Now, as you probably know, if you take a really strong concentration of cytokeratin 7 and stain the cervix, you'll stain a lot of cells. If you dilute it out, it gets more and more specific to where you're really only picking up, at least with any kind of strong staining, the cells near the SC junction or just beneath it. It doesn't mean that all the cells are at the junction, but a lot of them are, and most of your staining will be within very close proximity to the junction, at least in this particular model. So there's kind of 3 stories. There's a cell of origin story. There's a classification story where, as you begin to understand the junction and the neoplasms that come from it, you begin to sort of understand perhaps why the cervix is so difficult to diagnose, because there's so many different types of phenotypes that could be transformed by HPV. And then, of course, there's the issue of prevention. If the SC junction cells are right there, is there some way you can prevent cancer or lower the risk, by some mild or minimal type of ablation technique? So in terms of the junction, this is Michael's diagram, and these are too small to read, but basically these have a number of properties. They're different. They have different receptors. There's different aspects to the SC junction cells that make them unique, that might explain why they're different, or why infection of those cells will give you a different outcome than if you infect, let's say, the mature squamous epithelial cells. And this is just a good example of very early HPV infection at the SC junction, which you don't see very often in the histologic section. Here you've got cytokeratin 7 staining, and notice how it stains the junctional cells right as and they also kind of sit on top of the squamous epithelium. And then when you stain this one with P16, it's intense, meaning it's HPV infected. This is a very early lesion developing in the SC junction. Notice the cells beneath are the reserve cells do not stain with cytokeratin 7. No, not much at all. Once you get squamous differentiation, you lose it. Your cytokeratin 7 drops significantly, although it'll still be retained to some degree. And so we believe this is a kind of a case for what you might call top-down differentiation. where you directly infect the SC junction cell, and as it begins to proliferate, it begins to differentiate and basically undergo reserve cell differentiation, like you might see during embryogenesis, except in this case it might be due to HPV infection, which causes proliferation. And then what you get is a lesion, which looks largely squamous, as you might expect when you're looking at the cervix, or glandular. So we came up with two different ways you can infect. This is the classic way, and if you look at most classic texts, they say you need to have a break in the squamous epithelium, you introduce the HPV, it hits the basal cells, it starts to proliferate. And we believe this does happen a lot of times maybe with SCJ negative lesions on the ectocervix or in the vagina or in the vulva. And many of those are lower grade. They're not as high grade as the ones you find at the SC junction. Any of you who do colposcopy, which is probably not many, but if you do colposcopy and you look at the cervix, the classic mistake you make when you're starting out is you biopsy that little, white lesion out on the ectocervix, when you should be looking at the SC junction where the little gray lesion is, which is often the lesion you've got to worry about. And that's the difference in terms of risk. But the other way of infecting is that you get direct infection of this single layer of SC junction cells, and as the cells begin to proliferate, they undergo squamous differentiation, and they stain with the keratin 7 marker. So this is just an example. You'll notice this is a high-grade squamous intraepithelial lesion. It stains with keratin 7 primarily on the surface. It'll stain entirely with cytokeratin 7 when you get a really early lesion, where the cells really haven't started differentiating. But once they start differentiating, you only have staining on the surface. Notice you have P16 throughout the lesion, and I believe these are some of the residual embryonic cells or SC junction cells on the top, which also contain the HPV. And also we've done studies of latent infection or morphologically unrecognizable infection, and you can find it in these SC junction cells. So why cervical precursors are difficult to classify? That's the next question that comes up, because then you go from kind of theory into looking through the microscope. And this becomes a little difficult to explain, because now you're trying to sort of sort out what you're looking at through the microscope. Well, the problems with classifying cervical pre-invasive lesions is the target population is so varied. You have ectocervix, you've got mature transformation zone, in other words, cells that probably came out of reserve cells that are maturing much like the ectocervix. You've got immature transformation zone, which is like immature metaplasia, which are cells that have not yet matured, and you can infect all those cells probably. And then you have squamocolumnar junction cells, which you can infect. And as you might expect, depending on where in the maturation process you infect the population, you may get different phenotypes, which may be very difficult to sort out to the pathologist. And I can guarantee you, every pathologist in the room can say, I know the low and I know the high, I just don't know what to do with the middle, right? Everybody has the same problem. And that's one of the reasons why sin 1, sin 2, sin 3 is a false concept. Because, you don't even know if it's a continuum. You don't really know what you're looking at. I prefer low, high, and I don't know. And actually, if you tell a nurse practitioner, I don't know, they said, fine, we'll bring her back in 6 months. We won't, because we don't want to leap her in it. We're tired of leaping people, right? So that's probably... Anyway, so I think the likelihood of AIDS still is governed by the type of differentiation of the cell infected. The earlier in its phase, the more at risk it is for probably becoming a significant neoplasm. So here's your transformation zone, which is that area between the original SC junction theoretically and the current SC junction that is matured. And then here's your SC junction cells, which are staining with cytokeratin 7. Now don't ask me why the SC junction cells are riding on the front of the wave here, but that's where you'll find them, if you're going to find them. But as you might expect, if you infect this epithelium with HPV, you don't usually get cancer. What you get is lower grade lesions or lesions that go away. If you infect the outer mature T-zone area, you probably get about the same thing. But if you infect the SC junction or that area, you're more likely to get a high-grade lesion. But it's not a guarantee. And it's not a guarantee that an SC junction marker is going to predict cancer. Because as you know, there's another variable that we don't really understand. It might be smoking. It might be a number of other factors. So what we learned was on the ectocervix and mature transformation zone, lesions are usually low grade and they lack the SC junction markers. So they just don't express them, right? And if you go on to the SIN 2, 3 or squamous cell or adenocarcinomas, they occur, they're synonymous with the immature transformation zone or the SC Junction region, and they're positive for these markers. But there's always going to be something in between, and that's these immature variants that occur at the SC Junction. We used to call them SC Junction SYN1s. The trouble is my SC Junction SYN1 might be somebody else's SC Junction SYN2, right? Because once you get into the SC Junction, it becomes more difficult to clearly separate lesions because of maturation or other aspects of their morphology. Yet, if you get 3 pathologists and they all agree that an SC Junction lesion is low grade, the odds that you'll have a high grade lesion 6 months or a year later are very low. It's often just basically if they can agree on it. And this takes us to the issue of progression. People love to say, well, we can predict progression by doing P16 staining. You can't, because no one knows what progression is, right? You have to get people even to agree that the first and the last biopsy were different. In my experience, and generally, if someone tells me, well, it was SYN1 2 years ago, now it's SYN2, and you show it to 2 other people, they're going to probably say it was SYN2 2 years ago and SYN1 now, because you can't get it to. So I've always been very critical of so-called progression papers, because no one knows what progression is. Often it could just be a new lesion. You have to type them to be sure. This is a series of cases that Wenqing Zheng and his colleagues published years ago called eosinophilic dysplasia of the cervix. But what they were putting their finger on were kind of metaplastic dysplasias, which are less mature and difficult to classify. And I think these are lesions that are almost always SC Junction marker positive. But the reason I showed them is because they look less mature and you may have more difficulty classifying them, but in reality, you're just looking at a nuance of the SC Junction region that you have to deal with. And these are the ones that are more difficult because there are no good criteria for separating them. It's a gestalt. And if you stain them with P16, they're nice and strong, you see. And so it's very difficult to come to a real conclusion as to how to separate lesions in the cervix. Most lesions arising in the SC Junction do not progress to H-cellular squamous cell carcinoma, and biomarkers don't give you a lot of information. P16 staining reflects HPV type category. So strong P16 staining means a high-risk HPV. We all know already that high-risk HPV is not enough to predict what's going to happen. And the 6 and 36-month regression rates for SYN2 as we know it, even when we look at it and say it's SYN2, and we think we know what we're looking at reasonably well, we can get agreement on it, still very high regression rates for these lesions. There's significant problems with inter-observer reproducibility of SYN2. So I take 3 of my fellows and I say, okay, is it SYN1, SYN3, or SYN2? And their kappas for SYN1 and SYN3 are like 0.6 or 0.7. And for SYN2, it's 0.2 because they can't agree. That's why I like the word uncertain grade, because we're uncertain that we even know what we're looking at, basically. And you can't prevent squamous cell carcinoma by trying to select which cells are going to progress. It's really very difficult. So this is just some good examples. This is an SC Junction negative low grade, pretty easy to identify. SC Junction positive high grade, then SC Junction positive in-betweens, where you just aren't really sure what you're looking at. What's interesting, though, they have a fairly high frequency of HPV 16. Almost always have high-risk HPVs, meaning SC Junction region is kind of high-risk HPV specific or preferential, which is kind of interesting. And so this is, for a pathologist, I think most will call this low. Although I've shown this to large groups and got 20% to call it high. So, there's no way. So I'm not going to, and most will call that high grade. Maybe 1 or 2 will call it low grade. I don't know why they do, but, But then you show this lesion, they say, well, I don't know. It's kind of difficult. It's got good polarization. Someone in the crowd always says that's SYN2, or that's. Another person says, I don't know. It's kind of funny metaplasia. But to me, this is the in-between. And these are typical SC Junction lesions. They're very strongly positive for P16 and for CK7. So we have a different perspective. We see three categories, and what we generally do is we'll still use the word SYN2 if we're pretty sure, but often we'll say this is undeterminate grade. It's somewhere between SYN1 and SYN2. And 20 years ago they'd have gotten really upset because they want to leap them, right? Leap them or follow them. Nowadays they'll say, we'll just follow that borderline SYN2, and I think it's the best way to approach patients. But I like to get rid of the SYN2 because SYN2 is such a pejorative term. People are so fixated on it. So I like the low, high, and intermediate. You sort of get away from using traditional terms that had no meaning to begin with, really, not in practice. still low risk. So what about SC junction cells and early infection? Well, it's interesting if you do laser capture, and we did this study by taking SC junctions from patients who had lesions, but the given section we were looking at did not have a lesion. So we wanted to take patients we knew had HPV infection. And what we did was basically just laser capture the SC junction cells and then the endocervical cells, or the cells that were CK7 positive, and then we dissected the others, and we found there were a couple of markers that were interesting. Number one is keratin 7 highlights those cells. An HPV E2 antibody, there's an HPV 16 E2 antibody that someone, who was it, came up with a few years back, which they felt highlighted early infection. And it's kind of cool because it does stain these cells, and if you microdissect those cells, you can actually identify HPV in them, in them by sensitive, PCR techniques. And it predates P16 staining, and so in some cases you had just the HPV E2 marker. Others you had E2 plus P16, but you didn't see anything happening yet. Then of course you get P16 positive lesions. So we felt that this was just good evidence that the SC junction cells could harbor latent HPV. Doesn't mean they're ever going to become anything, but we felt that they may be a target for latent HPV infection. Certainly you can find it elsewhere, but we felt that was important. So what about SC junction cells and cervical cancer prevention? Well, does the SC junction phenotype confer a greater risk of HSIL? Yes, it does. There's a high percentage of HSILs are CK7. The CK7 positive low grades have a high frequency of HPV 16. The vaginal and vulvar epithelium is CK7 negative. Other lower genital and anogenital tract sites also have a lower risk of developing cancer. And if you look at relative incidence rates, and this figure can vary depending on whether you're looking at screened or unscreened populations. But throughout the world, there's a 15 to 25-fold greater chance of getting a cervical cancer than getting a vulva, vaginal, or anal cancer. And the first thing you think of, well, the anus must have an SC junction, right? And it does, but it's different. We looked at a lot of sections of anal-rectal junctions, and we did not find a single layer of SC junction type cells. They may have been there at one time, but during embryogenesis, something happened to where they began to proliferate and stratify, at least the CK7 positive population. So we came to the conclusion we were not looking at the same thing. And this population may be further along or in some way less vulnerable, we thought, to high-risk HPV infection. As you know, in a gay population, gay men, for example, there's a lot of HPV in the anorectal region. What you don't find is a ton of cancer unless they're immunosuppressed. So that's the difference, And probably it's the same with women. Women have a lot of HPV infection in their anogenital region, but it doesn't mean that they're going to get cancer. So there's something different, and we thought that might relate in part to not having classic junctional cells. So that's what we believe was true. That may not be the real answer, but we thought that was a reasonable argument. Another thing we discovered, at least in the first study, and we really haven't done enough to prove this, in my opinion, was that when you took patients who had LEAP and you stained their new SC junction, you didn't find the cells, suggesting that you can actually take them and remove them. Now, I don't know if we have another, I don't have the slide, but I'll just back up. But Michael Herfsen we did another study together in Belgium where they basically took women who had had cone biopsy and followed them to see what their recurrences looked like. And basically what we found was you had maybe about 13% recurrences after cone. And if they occurred immediately, they were SC junction positive, suggesting they were residual disease. If there was an interval of a negative pap smear and they developed a lesion, they were almost always SC junction negative lesions, meaning the SC junction had been removed and you had an ectocervical recurrence. And they were virtually all low grade, and most of them went away within a few months, suggesting that when you do remove the SC junction, your recurrences will be mainly ectocervical, which was always observed by a lot of colposcopists. You don't get a lot of SC junction region recurrences. They tend to be out on the ectocervix, suggesting that if you were to remove the SC junction ahead of time, you might favor infections on the ectocervix or vagina where there's less risk than if you had it in there. And that was what we felt was a reasonable argument. So the conclusions with the residual cells populate the junction. They're targeted by carcinogenic HPVs. The SC junction cells give rise to, they can give rise normally to more mature, less vulnerable reserve cells and squamous metaplasia over time. They're progeny. The SC junction, though, is at least 15 times more susceptible. And that raises the question, will preemptive ablation lower the risk? Well, as I mentioned, recurrence rates of SIL are exceedingly low in the cryotherapy era when both LSIL and HSIL were treated. Particularly if you had 3 negative pap smears. If you had negative pap smears after a cryo, your chance of a new lesion was like 0.4% or something. It was very, very low over time. Most recurrences are low grade and do not appear to originate in the SC junction. High grade recurrences following an interval of normal cytology are uncommon. And there's anecdotal evidence, as we mentioned, from Gustafson and their observations. These are studies that were prophylactic studies, and a couple of them had something wrong with them. In this study from Denmark, they had a 6-fold reduction in cervical cancer incidence if they cauterized normal cervices. The problem was, I'm not sure their case and control groups were well matched to really remove some of the bias you might get. This person here had a 54-fold lower risk of squamous cell carcinoma in the population that they did cautery on. The problem with their study was you don't know whether their case controls were the same. Their controls, the ones who got the cancer, for example, might not have had as good a surveillance. So that became difficult. These are interesting, though. In Taylor's study in South Africa, they took women, I think they were HIV negative and HPV negative, and they did cryo in the cervix. They noted about a 50% drop in the frequency of HPV infection. I'm not saying HPV infection would even be prevented by doing cryo, but they noticed at least a 50% drop. And they said, we don't know why is this, we don't know why this happened, but there's a drop in the risk of HPV infection. Kuhn's study, which I like, they took HPV positive women who were cytologically negative, cryoed them, and noticed a 70% drop in the risk of SIN2 going forward. SIN2, as you know, is not a great endpoint. You'd prefer SIN3, but nobody really used it back then. So again, suggesting that cryo did something to reduce the risk. So to me, HPV testing, in my opinion, as non-specific as it is, should really only be used maybe once. I mean, in a global sense, or very infrequently. You might test a population, and then, if you're in a high-risk area, then go ahead and do some kind of ablative technique. You probably should do some minor ablation of everybody's SC junction if you could do it safely, which I think you probably could with with a light hand, for example. Otherwise, you've got these algorithms that you're all aware of in practice. My oncology friends always telling me, another algorithm just came out. So what am I going to do? So to me, I think you should probably take reproductive age women, test them for HPV, and if you want to do a study, it'd be very easy to determine how much success you're going to have with cryotherapy, with a 30-second or a 1-minute flat boiler cryoablation of the cervix to see if you could reduce their risk. And this is how you might do such a study. You take your HPV positive cytonegative population, of which we all have. This is probably fundable. It's hard to get people who are wrapped up in the HPV industry to get excited about it, right? So, I gave 3 lectures of 3 major HPV groups, and they're finally going to do a study in South Africa, on about 5,000 patients. But everybody else is probably already on a speaker's bureau for somebody, right? So it's difficult to get excited about taking a cryo and doing ablation when there's no money in it, right? So you could ablate cases and have controls and follow them, and there's several endpoints. You could look at their HPV status 6 months from then. Did their HPV go away? May not, right? You could look at their cytology. Do they develop lesions? Do they develop a lesion? What's the grade of a lesion? And where's the lesion location, and is it SCJ positive? That'd be a great study. You ablate the T-zone or the SC junction region. They come up with a lesion in 1 year, and then you can determine, is it SC junction positive? If it's not, you made a very good case for prophylactic ablation because you've created a lesion that is not considered to be at high risk. And so to me, that's a study that needs to be done. This is just a concept, but I think it's an important thing in the interim while you're waiting for an HPV vaccine to come to some of these countries. The caveats, the real caveat is we don't know the distribution of these cells. And sometimes they may be further up the SC junction. That might be the major issue that you've got to deal with. Or not further away from the SC junction, further up in the canal. So with that, let's just take a quick look at high-grade serous carcinoma. We'll just go spin through that in the last few minutes because it has a similar kind of story where you can break down the issues into three different categories. One is this high-grade serous carcinoma, which historically, as you know, is a tumor that has often been presents at very high stage. It's very lethal, very difficult to prevent. Anybody who was in the CA-125 era, would know that CA-125 is not a good marker because, as Scully and Debbie Bell showed years ago, about 90% or 95% of your cases are going to present in advanced stage. So there's no early serous carcinoma out there that you can detect most of the time. And again, there's like three different concepts. There's the cell of origin issue in the fimbria. There's classification of precursors, and there's prevention. And these are all three issues that come to bear. And if anybody's interested in this, I'll be happy to leave it on the screen if anybody wants to get the information. The fallopian tube is very exciting. I think and Mary Claire King's discovery of BRCA1 is really one of the major reasons that it was discovered, although we were looking at tubes and ovaries in the 90s without much success. Sweemer did a very nice study around 2000 finding molecular evidence linking some cancers of the tube to the BRCA germline mutations. And then others came along and made the observation that there were dysplastic changes in the fallopian tubes. So what we did was we came up with the SEE-FIM Protocol, which is just a marketing tool. It didn't pay me anything, but it's I said, well, so it's sectioning, extensive examination of the fimbria. So basically what we did is we just suggested that people section the fimbria more carefully. And it was very effective. People came up to me like 2 years later and say, I thought you had no idea what you're talking about, but this does work. And they got to do it for themselves, right? Because I didn't have to convince them. They just did it, and it turned out to work. We learned it by just doing this, and we started this like in January of 2005, and we had a bunch of BRCAs that came through for prophylactic. And in 3 months, we had 5 early cancers in the tube. We didn't see another one for about 3 years, but lucky for us, they came at that time, and we were able to make a connection. So what happens, if you look at early serous cancer in the BRCA positive women, they almost always appear to be arising in the tube. Not all of them, but almost all of them. And this is where it gets interesting, because in the early lesion, where you're screening, about 5% of BRCA women being screened after risk reduction surgery will have a stick, a tubal intraepithelial carcinoma. And what's all equally interesting is if you take a population of women who come in like with symptoms, and they're already stage 3 and they got a lot of tumor, it's about 40%. Some people translated that to meaning all. I was always a little cautious because I said, I don't know. I'd like to see like 80% or 75%. And I wasn't able to see that. And some people saw more than others. We averaged about 40%. But this is a great example of how it might happen. You have an early precursor. It develops a small tumor in the tube that you can barely see, and you get a big tumor in the ovary. It spreads. And I think that makes perfect sense. I'd say for the pathologists, whenever you do get cases that come through the frozen room, just very gently palpate the fimbria for any 1-2 millimeter nodules, and that might be the tumor. Sometimes that is the tumor. And the precursor concept came up because when you looked at these tumors and you looked at the adjacent epithelium, you could find rather bland appearing adjacent epithelium that was strongly p53 positive. And when you looked for mutations, you were able to find the same mutation that you found in the tumor. And this came up with the concept of the p53 signature, which we found about the same time. And it has exactly the same distribution as the intraepithelial carcinomas in the fimbria. They just lack the proliferation and the atypia, obviously. But otherwise, they're quite similar. I think they tend to be rather small and limited in extent because you're probably hitting a stem cell or hitting a proliferating cell, and it has a certain number of doubling times, and it quits, right? And so most of your signatures are indolent. They have a p53 mutation, but they may not have a significant growth advantage. So a lot of these early lesions don't have a growth advantage, and they start and end. 50% or more of women have these in their tubes. You know, it's just like 50% or more of women have been exposed to HPV or right, and they don't get cancer. So these are early latent precursors that in most cases don't do anything. But and this is your sequence. You have your signature, you have your stick, and then you have these tweeners, if you will, things that we call uncertain significance. I think Bob Kerman called them intraepithelial lesions, which we used at one time. But I kind of like uncertain significance because that's really true. Even when you get to the sticks, they have an uncertain significance in a prospective population. So it's important to keep that in mind. It's also important when you talk about stick is to separate out the sticks in the risk reduction population, which are almost always primary and early, from the sticks in the patient who's got widespread cancer. Their stick may be late, or it may even be a metastasis to the mucosa. So you have to be very careful in using and sort of using stick to group both of those together. They're really different, maybe different entities. And so everybody's got their timeline, right? You know, where you start off with a mutation which then can expand, and then it takes some kind of additional event, BRCA inactivation or some other changes in the epithelium to cause it to become a stick, and then obviously for cells to release and then spread to the peritoneum. And this is not well understood, and we don't really understand why how this occurs, because it's not as common as you might think. So from this, Pat Brown, came up with that, his timeline, highly theoretical, as you might expect, where you develop a tick after genotoxic injury, then you may have a window of an opportunity of a certain number of years, and then you get cancer. And there's certain weaknesses to this concept. What do you do when you have a woman coming in whose sister has breast cancer? She's 70 years old, so she says, take out my tubes and ovaries. You take them out and she finds she's got a stick. Then she says, bring my daughter in who's 50. She comes in, you find a stick. Now, have they been sitting around with a stick for 2 years? For all you know, the stick could have been there for 15 years, 20 years, and just not metastasized. So it's very difficult to, the so-called tubal pathway may be the slow pathway. We always think of high-grade serous cancer being rapid, right? She was healthy 1 minute, and then 6 months later she's got a grapefruit-sized mass in her pelvis. And you say that's a rapidly developing cancer. Well, it may not be. It may have sat in the fallopian tube for who knows how long, right? For 15 years before becoming malignant. So when you think of high-grade serous cancer, there may be a slow and fast pathway, but the slow pathway may be in the tube, and the fast pathway may be one we don't understand. That's probably the best way I can think of it. So can we target the tube? So there's the bandwagon for the tube. Everybody became excited about that. The British Columbia group really gets credit for pushing it. And I'm not going to give them blame because I think it's a good idea to do opportunistic salpingectomy, but I don't know how successful it is or how successful it will be. We'll have to find out. And there was a study that was done that came out in JNCI that inferred about a 50% reduction in risk if you took the fallopian tubes only, based upon retrospective data. That's really not well understood. The theory being if you took out the fallopian tubes and a woman in her 40s, her chances of developing ovarian cancer would be halved. And thus there's a big push now to do opportunistic salpingectomy. And ACOG, of course, is now, and the gynecologic oncology groups are all recommending doing this if possible. Now, what are the caveats? Well, there are several things we have to figure out. The frequency of stick in the population, just walking around population, the frequency and timeline of a high-grade serous cancer outcome, the frequency of stick with high-grade serous cancer. Are all sticks primary? And they're probably not. Some of them are probably mucosal metastases in the advanced cancer patients. And is there another pathway? Well, the frequency of stick has been estimated around 1 to 300. I can tell you, I don't think that's what it is. We looked at about 2,000 cases at the Brigham, because we've been doing SEE-FIM Protocol for about 10 years. And we found about 1 in 500 or 1 in 800 was our frequency. What was interesting is the majority, at least half the sticks we found, of like 3 of them, were associated with endometrioid adenocarcinomas or endometrioid neoplasms. A completely different entity, right? So is that just because we look at the tubes more carefully in those patients? I don't think so. Now, you would think so, but we look at the tubes carefully in everybody. we found maybe one in a population you'd consider the low-risk population that you might do opportunistic self-injectomy in. So sticks are not common in my opinion. They're just not common. You occasionally run into one, but they're hard to find. Many are found associated with endometrioids, and the frequency in the low-risk population is uncertain. So when you start talking about all the women out there at risk, now, of course, when you do the opportunistic self-injectomy, you're not expecting to find neoplasia. You just want to get the tubes out before neoplasia develops. But in our study, they were all women over 50. So we were kind of selecting for a population that might be at risk, and still it was very low. In terms of outcomes, based on meta-analysis, if you have a stick that's picked up during risk reduction surgery, you've only got about a 5 and at most 10% risk of coming back with a high-grade serous cancer. It's a low risk. So some people say you shouldn't even call them sticks because it's so low. But that's, and this is despite a wide range of age when you discover them, because this is all random. You know, a woman comes in who's BRCA positive and she has her tubes out, and you find a stick. You don't know how long it's been there because there's no way to test. So it could have been there forever. And what's interesting is it's also difficult to separate the curves for stick and high-grade serous frequency in BRCA positives. So you know how most of us think of, like, if CIN3 has this curve and cancer has that curve, right, in terms of time, because it takes a while to go from one to the other. And yet when you superimpose patients with stick on patients with cancer with BRCA, they're pretty superimposable, making it difficult for you to understand how long, when women are walking in 35, 40, 45, and 50 with symptomatic ovarian cancer who are BRCA positive, you very often don't find a stick. So what happened? What made these, where did it come from? And why are sticks and the cancers about the same age distribution? You'd like to see them kind of have two peaks, wouldn't you? Maybe not peak, but at least start earlier. Sticks would start earlier and then the cancers come later because there's a lag. It's very difficult to prove that. And the other thing we had trouble with from the beginning was about 1/2 of women with a primary peritoneal or ovarian cancer who just walk in the door, who are symptomatic, had a stick. And about 85% of women who come in who are asymptomatic, who are BRCA positive, have a stick. But when you took the symptomatic BRCA positive patients, the stick frequency was quite low. So, and I kept saying this over and over, you've got to be careful making major judgments on your asymptomatic population and extrapolating it to the entire population. So, there's, to ours, not all serous cancers are the same, and I think you can segregate serous cancers a little bit on morphology. There's classic high-grade serous cancers, and then there's another type of high-grade serous cancer that's called set pattern. And it's interesting. We suggested separating them into endometrioid-like versus high-grade serous-like several years ago, and then a group of individuals I will not name got together and wrote an editorial saying we should lump them all together because we shouldn't try to separate serous cancers based on histologic type. We came back and said, well, I think you probably should until we understand what's going on. And one of that group then came up with, about a year later, with a new type of serous cancer called the set pattern, which was a very good observation. And they came up with a population of serous cancers that look a little more endometrioid-like. And they're a little bit different in terms of their association with stick. So here's your classic pattern, here's your set pattern. See? And they all have the same number of p53 mutations. They have almost everything's the same, but they're morphologically different. It turns out the set pattern is a bit more frequent in the BRCA-positive population than the sporadic population. And in the sporadic population, the set pattern has a much lower frequency of stick association than the classic pattern. Now, these obviously are statistics based on relatively small numbers of cases. But from this, we concluded that there might be a couple of different types of serous cancer with different frequencies of recognizable tubal precursor. And this is not highly subscribed by everyone, but we think there might be two different. So we believe there might be a couple of different models for serous cancer. One of which is the traditional model, where you develop the cancer from a stick over time. And then there's a different pathway that is either an alternate precursor or it's maybe coming from the tube by some other mechanism. But whatever it is, it's a tumor that sort of shows up all of a sudden without a clear-cut primary in the fallopian tube. And we've serial sectioned cases without sticks, and maybe found a few sticks, but the majority of cases when you serial section the entire fallopian tube, and you don't find the stick. It's just not there. Now, could it be a precursor escape? Could a few cells get loose earlier in time and go on the peritoneum and produce malignancy? That's possible, but we don't know. We just don't know what's going on. So in summary, it's yet to be determined that risk-reducing self-injecting will protect women with germline mutations. There is a population of women that will, with BRCA, that will refuse oophorectomy, or they don't want it. But it's highly risky because, as you know, if you come up with a cancer and you're BRCA positive, you've got about a 70% chance of not being there in 10 years, as opposed to, if you have a risk reduction surgery, you may only have about a 4 or 5% chance of coming back with a relapse. So I don't recommend it until I understand where these things are coming from. I just don't. So I don't believe in it. But some women are doing it, so they may get some data. But the data they get hopefully will be negative data. Opportunistic self-injectomy is the safest way to determine the efficacy. It's just going to take a long time. You've got to take out a lot of fallopian tubes to determine how it's going to impact on the cancer. You'll probably need thousands and probably 10 years from age 50 to 60 to understand. And hopefully it'll have a major impact. But it shows an understanding of tumor origin is critical to devising prevention strategies. You really have to understand where the tumors come from. I think the CA-125 story is a classic cautionary tale where they pursued CA-125 relentlessly without ever looking at the pathology of those cases, where it was very clear that CA-125 was not likely to pick up or have a major impact on cancer death rate because the tumors almost always seem to start on the surface of the ovary, the surface of the tube, or somewhere. There's just no time. There's no window of time. So with that, I just want to acknowledge the grant support we've had and thank Frank and Wah for their help. Michael Hurst did a lot of the work in the cervix, and Ronnie Drakekin and Alexander Miron were really invaluable in helping us get started with this when we were at the Brigham. Young-Hee Lee was actually a visitor from Korea. She was she was a practicing pathologist in an academic setting. But as I always say, that when you bring people in the lab, there's 3 things they can do. One is they can be energetic. Number 2, they can have good hands, which is always good. And number 3 is they actually come up with ideas. And Young-Hee did all 3 of them. And she was always saying, you might want to look at this again, is what she would say. So she was, and that doesn't require a scientific background so much as just attention to detail. Ashraf Salimuddin was a young kid who was between college and medical school, and he was doing all the laser capture work. And he was leaving. As he was leaving, he said, "This will work." And I said, Ashraf, if this does not amplify by PCR, you're going to need a witness protection program. He said, "It's going to work." So, and it did. It was great. We went to his wedding. It was a lot of fun. Fabiola was a fellow, and what she did was she made the residents do SEE-FIM every day. She cracked the whip over the residents. Brooke Howard, was one we have now on our staff who's very productive and did some of the later work. And of course, the pathology departments and Gynoc and Dana-Farber were very important in giving us support for this. So just for those acknowledgments, I thank you for your attention. I'll leave it on the deck here if anybody wants it. Questions? Yeah.
So is specific DNA mutations detectable in the luminal fluid of the fallopian tube or the uterus?
Yeah, that's a good question. They've done studies. There are those earlier studies you're aware of where they did sample for p53 mutations, and I think there was some success, but I don't know. It's hard to do it with a stick because what you'd have to do is probably get a BRCA population, test everybody until you had enough patients that turned up with stick to tell. I was told by some that the testing for p53 had some limitations because of inherent mutations, and we noticed that years ago when looking at the endometrium. If you sample the endometrium, about 1 in 50 or so, you could find p53 mutational, and half the fallopian tubes probably have p53 mutational event. Whether or not that matters or not, whether that's exfoliated, I don't know, but I always felt that was a limitation to just looking at a single marker, because there's a lot of mutations occurring in that setting, but I don't think anybody knows yet. They'd have to basically take a population of BRCAs and just test 200 or 300 of them, which I think would be a good study. But as you know, as you widen your control group, you start picking up stuff. If your control group has only 10 patients, which most of these studies have, you don't find anything. If you make it 1,000 and 5 of them have something, you got problems, even 10 of them, because they have to be investigated. It's like with the CA125 issue. Yeah.
Thank you so much for this really good talk. This is exciting stuff for all of us here. In terms of your group has probably seen the most number of these sticks, like in the country, since you've been looking for them for so long. Have you guys looked at any case control studies to see if there's anything unique about that population, whether it's any demographics or other medical issues or other infectious disease issues, or that seems to separate the stick patients from the non?
Yeah, it's a good question. I don't know. The number of, once you get away from in the BRCAs, it's interesting. There are certain patients that we've seen that had a lot of signatures associated with their stick. So my theory, one easy theory to come up with is that maybe the amount of genotoxic injury that occurs in the fallopian tube or the ovary varies from woman to woman. Maybe certain women are more likely to produce, a genotoxic follicular fluid if you believe that's what's causing the injury, right? And then you might be able to segregate them that way, but that would require, it's not been done, but I think it's a good question to ask, because when you're looking at such a small number of BRCA-positive patients who get cancer, at least get sticks, if you will, and then some of them have lots of signatures associated with them, you get the feeling there might have been a more genotoxic environment, right? So I think that's a possibility that might separate them. Hormonal issues also come to play in some of these, but I don't know the answer. I think I've always thought it'd be a good question to take maybe women with stick and then separate those that had just the stick alone from those that may have a lot of other things happening in the tube to see if there was a difference. But I doubt if there's an epi difference. You'd probably have to look at their maybe the stimuli or whatever's going on from the ovary. And it's a difficult question to answer. It's a good question though. Same like in the SC Junction. Why do only a few people get cancer?